technological innovation is not just to know what is available, also to look at in what direction the science is advancing and how you validate them, then how you do trials of them, then you look the pros and cons, benefits, and then come back into real practice and then make them high level evidence like level 2A or level 1. So that is why it is very important to understand what are the technological innovation. I'll give one example. Just 5 years back, if somebody has told that if you have some, so as you are aware, worldwide the head and neck cancer approximately, about 9 lakh cases are there and still 4 lakh deaths are there. As I always told you, when you are a surgical oncology student, initially we all thought that all the cancers behave and believe and formulate and follow the rules of Alstadian principle. What is Alstadian principle? There is a tumor, it grows by contiguous spread, then it gets an access to lymphatics, it goes through lymphatic emboli, then it goes to the regional lymph node level 1, 2, 3, 4, then it goes to higher echelon nodes N1, N2, N3, and then it goes to non-regional nodes, gets access to the blood, then it goes to lung, liver, bone like this. But we now understood that cancers, how much ever early they are, even if they are T1, they will not believe the Halstadian principle. That is when the Fisher hypothesis came. That most of the cancer, once they cross a critical mass, like say 2 centimeter in head and neck or 1 centimeter in solid tumors, they have a potential to have a systemic metastasis even without loco-regional extension, spread or advanced nature. That was the Fisher's hypothesis. So most of the cancer follow Fisher hypothesis, but there are only few cancer even today follow Halstadian principle. What are they? Squamous cell carcinoma of oral cavity. It's unlikely in a squamous cell carcinoma of oral cavity, without locally being advanced, without having system, neck nodes in the metastatic nodes in the neck, there will be lung mets or liver mets. So oral cavity squamous carcinoma even today follows Halstadian. Similarly, squamous cell carcinoma of penis, squamous cell carcinoma of vulva, these even today follow Halstadian principle, which means primary, advanced becomes T4, lymph nodes, higher nodes. That is one of the reason in oral cavity squamous cancer, the cause of death even in terminal state is not liver mets, lung mets, brain mets, bone mets, no, but they are complication of locoregional, that is bloat of the carotid, fistulas, cachexia, nutritional deficiency, invading into the vital organs like trachea, esophagus and dying, which go on to show if you do a very good surgery and combined with a radiation where it is indicated, a locoregional control even in advanced head and neck cancers many times translates into systemic cure. No other cancer you can have an advanced disease, but you can do a very good locoregional job and still give cure. That is very important. Except post-cricoid and hypopharynx, where they can have 20% lung metastasis, almost in most of the head and neck squamous cell CA, systemic metastasis is very rare, very little. So a good locoregional job done by all of you with a radiation can translate into a cure in majority. So if you look back, 9 lakh cases, 4 lakh deaths, means most of these patients were not able to achieve a good locoregional control because of various factors. Either patient has come very late to you, or surgical expertise of nature of surgery, good radiation, linear accelerator may not be available, or concomitant chemo option may not be there. Patient is not able to complete treatment. So that is a sad affair. 9 lakh case and 4 lakh deaths. So this is the 7th most common cancer, and you know that India is the hub of head and neck. We call that the oral cancer capital of the world is us, which is very sad, and we constitute to 30% of all the head and neck cancers. With this rising burden, new technological advances play a very important role. Like, it is very important to understand radiological advances. Linear accelerator, IMRT, IGRT, proton, CyberKnife, selected, intraoperative radiation, they have taken leaps and bounds, salivary gland preserving, various factors. Among the chemo, starting from cisplatin, Now we have cetuximab as a radiosensitizer. I will show you the cetuximab ligand bind management of the neck nodes binding, and then immunotherapies. Nivolumab has come, Pembro has come in head and neck cancers. Excellent surgical technique, ultrasonic, laser, local extent, reconstruction of the mandible, 3D printing, and MRI with 3D imaging, getting a overall picture, and selected cases role of neoadjuvant immuno or chemo. So this all overall has actually changed the landscape of the head and neck cancer. Now first one is robotic surgery. Now robotic surgery is not future, it is present. Remember, in head and neck cancer already robotic surgery is not future, present in the right indicated case. It is very important to understand there are various reasons why a robot can be used through natural orifice. Suppose imagine somebody has a early cancer, you have chosen chemoradiation as an option and there is a residual disease localized, then the best chance for them would be excision without having to do a swing or exposure, which itself is morbid. There are some part of the surgery history where the path to go that itself is more morbid than the disease per se. Two things in the sternal region, mediastinum, chest and oral cavity. All you need to do is, suppose there is a posterior pharyngeal lesion. So, lesion is situated there, no systemic mats, it has been adequately treated, local curable salvageable recurrence. To reach that area, you have to either go through a lateral pharyngotomy or a swing, or you have to do a mandibular swing. And because of that, you plate, sometimes you put a temporary tracheostomy, feeding tube, misalignment, teeth management, and plastic surgery. Once you go in there, all you need to do is exercise with a tri-dimensional 1 centimeter margin. And in case of hypopharynx, 2 centimeter margin, oral cancer, 1 centimeter margin. So that's why the access to that area is more morbid than the actually primary surgery. Like you take mediastinal surgery, cardiac surgery, sternotomy, go there, do a half an hour job, but then put back the sternum, put the patient on heart lung machine, bring back the morbidity of the reach is more. That is why the reach of the robot through the natural orifice is attractive. Because we all know that there is a 7 degree of freedom, 3D magnification, 5mm instruments are there in several platforms, and then you can go back there and excise it, control it very well, achieve a very good margin and come back. You can do a supraglottic laryngectomy, salvage excisions in the oropharyngeal lesion, base tongue, or alternatively, if you have say T1 well differentiated, this one, and you have done a neck evaluation, they're truly N0 either by surgically or imaging or by sentinel node, then if you can remove primary with three-dimensional, you can avoid radiation, which is a very important modality in head and neck cancer, highly curative, but it can be used only once, even though re-radiation can be done after 2 years, not very effective. So that's why the use of robotic is two-pronged. Very early to avoid radiation, so you keep the radiation. Remember, a successful survivor of oral head and neck cancer has a potential 4% chance of developing second cancer for every year they survive in their lifetime. And if the cancer happens in an area where surgeon cannot access them, or they may compromise the speech deglutition or the laryngeal function, then radiation may be used. If you have exhausted already, then whole life you leave that guy without anything unless you do interstitial brachy or you do a IOER, intraoperative linear accelerator. That is why transoral robotic surgery is one of the development. I can't expand on this because these are separate talks. I'll just leave at this. But to do this, you need special retractor called FK retractor. So I have made a lot of special retractor. There are local vendors in India, in Delhi who make. I have the original FK, the Indian one. So you use them, then you go back and you can access those areas posterior to circumvallate papilla, tonsil, then base tongue, posterior pharyngeal wall, oropharynx, then posterior supraglottic area. These you can do that. So these are all the advantages I have put. They would usually need a good retractor because they are gasless surgery, because there is no gas to distend. You need, like in thyroid you can do gasless and with gas. So when you use gas, then you need those retractor. If you are not using gas, then you need those retractor. The advantage would be you don't violate the mandible, you don't have a scar on the face, and then so quicker recovery, cosmetic and rehabilitation, all this. So, but these are in selected case. You don't do a robotic TORS. If you're eventually going to use chemoradiation to primary, please don't do that. Use one modality and achieve a good negative margin. So patient should derive a benefit, either a good surgery or chemoradiation, not both. Then it is a double whammy, double cost, double complication. Or you're treated with chemoradiation, there is a localized recurrence, then you go for salvage. So these are the issues we need to do. So I will end this part of the talks by inviting all of you to read a ORATOR trial, because when new evidence come, always take it with a pinch of salt. Look for evidence. Just because you have a hammer, everything should not look nail. Oh, tomorrow you have one T3. Oh, I'm going to put a robot and do T3 primary lesion. You're going to end up with radiation. Why you want to exhaust this? So please, or you will say that, oh, there is an N plus node. Now I will do a transaxillary neck dissection. Please don't do that. In a N plus node today, robotic surgery for neck dissection is not level 1 evidence. Staging N0, you can do a good sentinel node if your institute is validated your result, you have followed them, you know how to do, you have tried, or a robotic transaxillary, posterior cervical, various technique of neck dissection. But don't do a wrong thing just because you have a hammer, everything is not nailed. So, randomized trial of radiation versus transoral robotic surgery in oropharyngeal squamous cell, long-term result, ORATOR trial you can see. In the selected right indicated patient in the hands of expert in a advanced head and neck cancer managing unit at a tertiary care cancer center in the right place, it gave an equivalent result, but the complications which comes with the radiation, like dry mouth and various other issues, nutrition issues, was less. So please go back and read that, and then we'll evolve this as the things happens. Now second thing is, most of the robotic platforms are multi-port. That is why people are not comfortable. You put a FK retractor, then put 4-5 arm, they keep struggling outside inside. How much our endorist is there, there is a 3D vision. That is why single port came. So one company brought the single port access. So now single port is available in like 6 to 7 platforms in the world. Shuri from China, then there is also from Japan. Now there are 2 from US, 1 from Korea. And also now from India, the SSI robot, the Indian robotic platform is also bringing a single one. And now there is a Israel company which has launched it last week in India. So it makes attractive that you put a 2.5 centimeter single cannula through the arms open. This will revolutionize the head and neck surgery, because putting the retractor going around is not easy, because all vital structures are there, pellet is there, osteopharyngeal wall, turning back into the hypopharynx, larynx is not easy with the multiport. So you can see that this is a new robot which is already available. So these are the multiple. Now this is another port. You just fix it to the headlight. Those people who do laryngeal surgery micro, they already know. You put a suspension laryngoscope arm, open the mouth, you do a laser surgery. The tip of them are 3 millimeter. It looks big. It is not even half of our hand. So you can just put a single rod, then it can go down, and then you can do this head and neck surgery. Now this robot was launched last week in India. This is an Israeli robot. It is called Mesoflex robot. So the beauty is they are 1 to 2 millimeter. It has got a monopolar, bipolar, grasper, cutting, all included in 2 blades. The beauty is it can go back, turn and do it. Imagine you can put it back into behind the pellet, it can come back to nasopharynx. Imagine operating an nasopharyngeal tumor through the transoral route, not during the fest. It is already available, it is already launched in India. It's an Israeli company, and then the distributor for this particular Mesoflex, very thin robot, with 2 arm, which is flexible. This is the most flexible single arm robot ever made in the world. It can turn front, back, 360 degree, side, left, anyway. And Merrill is marketing this. So these would actually revolutionize. Now I had a honor of visiting the Robotic Innovative Technology Congress in Orlando. Now they have brought a new robot for microvascular anastomosis. You know that a good microvascular unit like Dr. Kaustuba is. They do the resection, they do the microvascular, and they are one of the few qualified surgical oncologists practicing head and neck who is to do their microvascular reconstruction. Imagine if you have a robot. This is a miniature robot called Mira, specially released for microvascular anastomosis. So you can go and anastomosis. Many times you have to open jaw split to reach that area for anastomosis or inserting the flap. This robot is specially made for plastic surgery. for lymphatic anastomosis, microvascular anastomosis, and to reach the area of deep skull base or parapharynx where your hands cannot reach. This is also already available. I've seen this. This is the photos I've personally taken. If you know, the size of this is less than the Yankur suction you have. It is less than that. And surgeon sits on this, and there are multiple foot pedals you can compare. They're almost, can you see this microsurgical instrument? The end is this. So it just goes on a platform like this, and it sits here, surgeon sits here and watches and operates as if you are watching a joystick or you are on a Xbox. So this is already available. So now this is another robot called Saimi. Can you see the tip? You can't even see the tip. It is like micro. It can hold 10-0, 12-0 suture material. It gives 20 to 30x magnification sitting on the robot. So these are all available. So this is a revolution in time. Also, you know that one of the recent advances which is fully adapted today is a robotic thyroidectomies. So there are various techniques. You can go through gasful and gasless. I've just classified it. Some other topic when a robotic thyroid happens, we will elaborate on this, but I'll just touch upon the advances. Traditional mini incision endoscopic, true endoscopic through anterior chest, axilla, areola are now gone through the robotic, gas, with gas, without gas, transaxillary, without gas. So you need to use a chance retractor. Now Indian counterpart is available already. I have purchased both of them. Or you can go retroareolar, transoral, bilateral axillary breast approach, or robotic axillary breast approach, or a facelift. So various techniques are already available. So these are recent advances which are reality in a right indicated patient. Just because I have done 160, 200 cases doesn't mean that. Again, remember, hammer and nail. As a surgical oncologist student, there are two things which you must very clearly understand to have a good head on your shoulder. Number one, what can be done is different than what should be done. Just because something can be done in oncology doesn't mean it should be done. Just because you learnt everything, there are 100 people, all the cases are resectable, it doesn't mean. Second, everything what is resectable is not operable. Just because it is resectable doesn't mean oncologically it is operable. So you must understand the knowledge over the skill decides what is resectable, what is operable. Without knowledge, only skill makes you everything resectable, and then the patient is never going to derive a benefit. So what can be done, what should be done, what is resectable and what is operable. So you know that I started the robotic thyroidectomy in India first. The first one was done in 2011 by me. Now I have done over 200 cases. That doesn't mean every thyroid is a indication for robotic. There are various approach available. Go back, I just classified like this: gasless, which means retractors are required, static, or with CO2 insufflation. Transaxillary retroauricular facelift is gasless, so there is a static retractor. With insufflation, bilateral axillary breast approach or transoral approach. These are all that is taught or robotic. So to do this, you need some special things. If you are on an older platform, Shrittel grasper is important. So this is important to manipulate the gland. So the advantage is, the whole advantage. Today there is no trial which has showed robotic thyroidectomy clinically is superior to conventional open surgery. Remember, don't get carried away. All that gets added is you can do an equivalent surgery in selected cases, in a selected hand, in an expert hand, without a scar in the neck which a patient may derive. How to do this? I have already published it. Please go back and read my paper. Google Journal of Minimal Access and my name. I published it several years back, over 200 cases. Technical consideration, or you visit my YouTube channel with my name, Dr. Somsekhar. All these video techniques are available. How to do, I have detailedly written on various platforms. How to de-roof the recurrent now, how to identify the parathyroid with ICG, so that after you finish the thyroidectomy, give IV ICG, throw a fluorescence, see parathyroid is vascular, not vascular, then you can reimplant them. So these are all the advantage and disadvantage available. Transaxillary, retroareolar, transoral, baba. Since my talk is not on robotic thyroid, I will leave at this point. Now the single port transaxillary has come. This is a robot called a Shuri robot. Can you see this? This is a Shuri robot. So you can do this surgery through. So these are called a start surgery or start neck dissection. So then you can just do this through single incision. So this is very attractive that is available. You can do through a single incision. Various robotic platform are there. There are a lot of publications called as START, single port transaxillary robotic. So you can see the pros and cons, but I will put you finally the evidence-based approach what you have to do. These are all the various surgery of 3000 cases which are published, and the pros and cons you must understand. But I will give you, it is very important to understand. Today, no matter who it is, who are master it is, I have done more than 200 robotic thyroidectomies. All approach, bilateral axillary, transaxillary approaches, best approach, but they take longer operative time. And then in the initial learning curve, you will have more nerve injuries, neuropraxia than other thing. And remember, if you do for malignancy, oncological safety needs to be very clearly done. So selection of patient is important. Now this is the guideline of ATA. When you should do a remote access thyroid surgery or not, please Google, read this. I've just left it here. You can take a photo of this, or if you put on the YouTube, I'll see. No matter what you do, I may do 200, another may do 100, everybody wants transoral, transaxillary, retroareolar, but the safety guideline brought by American Thyroid Association statement for robotic thyroid, 3-prong attack. Patient selection, thin patient, except you are doing facelift. Absence of excessive body fat along the flap of trajectory, along the facelift. Then the factors related to thyroid pathology. Lesion size, if it is well circumscribed, nodule should never be more than 3 cm, and the entire thyroid lobe should never be more than 5 to 6 cm. Tumor cap on the thyroid. Nodule may be small if the whole thyroid gland is big in that patient. Underlying thyroid pathology without thyroiditis on ultrasound. Thyroiditis today, even a remote access, is not strongly recommended. Remember, you may be able to do, I may be able to do it because I have done 200 thyroids. What can be done, what should be done? Factor relating to specific approach. Distance between axial and sternal should be less than 15 to 17. So please read this statement. Evidence-based indication recommendation brought by ATA and absolute contraindication to do thyroid. You may be God, you have done 1 million, I will do anything. Evidence of extrathyroidal spread, please don't do. Today, lymph node involvement is not a indication for thyroid access surgery in malignancy. Even though you can do a fantastic neck dissection, you may be able to do. Have you followed the group of 100 patients of thyroid robotic neck dissection done for 10 years, and have you proved equivalency of outcome locoregional control? No. What can be done? What should be done? Then Graves' disease, substernal extension. We can say I'll put the robot in the thorax, I will do, no problem. Have you proved the safety? Have you done 100 retrosternal extension of thyroid and analyze your result with open result at 5 years? No. So we'll wait. Previous neck surgery. Oh, I can do scar lysis. No problem. Today, when a society brings a guideline, these are the absolute. Okay, so I will stop at that point. So also read this recent STAR R&D using a single port. These are all the recent advances. So this is my paper. You can go back and read. When I completed 135 long many years back, I have published in Indian Experience, pros and cons. You can read it. Now I'll shift the gears. Come to next. In the entire solid tumor of oncology, solid tumor treatment, head and neck cancer, breast cancer, colorectal, esophageal cancer, lung cancer, penile cancer, abdominal cancer, surface cancer, salivary gland cancer, this issue is never solved. When we do a lymphadenectomy regional, you move MND1, MND2, 3, lateral lymph nodes, anterolateral neck dissection, posterolateral dissection, stay in this one. Are they therapeutic or are they staging? You know, now in CA breast, this debate is never closed. Axillary lymphadenectomy, is it going to give therapeutic benefit by removing those positive nodes, or we get more information what is the number of node involved, so we can give chemotherapy, immunotherapy, targeted therapy, anti-HER2 therapy, radiation. Lung, primary tumor with mediastinal lymphadenectomy, is it therapeutic or is it staging? Renal cell carcinoma, para-aortic lymphadenectomy, therapeutic staging. Please read this. I have written a very big chapter. I had been invited by the international body. I authored a 10-page paper. Removal of bulky metastatic nodes in solid tumor, therapeutic or just a staging? Please read. I have written a big article on that. So everywhere in the world, people believe there are two ways you need to know the nodes. Staging. In head and neck cancer, the moment there is more than 10 to 12% chance of occult microscopic metastasis to node, you need to do. If you read the JP Shah textbook of head and neck, JP Shah Atlas is separate, there is a textbook of head and neck also, JP Shah's. In head and neck cancer, if you have a good, robust follow-up, not Indian patient, they come only one time, last stitch of the suture is removed, they are incommunicado. In a ideal setup, if a patient is ready for follow-up, if you have a chance of 10 to 15% occult metastasis in the neck node, you need to do a staging neck dissection. Staging is to know positive or negative. If it is negative, you don't have to treat the neck with radiation and cause problem. Or you can convert it into a therapeutic neck dissection like MND or RND in an indicated patient. Or you can give radiation to the neck. So staging neck dissection versus therapeutic. Everywhere in all the solid tumor, even today in endometrium, breast, skin malignancies, melanomas, sentinel lymph node, penile cancer came. But in head and neck cancer, this is almost last part where sentinel node, because it is not easy. So the proof of sentinel node in selected patients of oral cancer came very, very, very late. The reason is primary and neck is very close. There is a shine through effect. Practically, there is not even a minute. In breast, 7 minutes you give a dye, blue dye or ICG dye fluorescence, you look. In all other place, you have 10 minutes response time. In head and neck, in oral floor mouth, seconds. So primary and level 1B is so close, difficult to distinguish the primary site of injection on this. Second, it is multifactorial. Bilateral involvement is there, right is there, you don't know. Second, many times to do microvascular reconstruction, you need a small neck access. So either way, you are in the neck with an efficient head and neck surgeon with a proper skin crease incision, they can beautifully do an SOHND. You already got a. Second, the morbidity of a well done functional neck dissection is not so high like other places. Usually lymphedema by a unilateral staging neck is not so like a arm lymphedema, leg lymphedema. And technology like a blue dyes, handheld gamma probe with gamma probe, where primary will also say 2E and neck will say 2E, you don't know, level 1A, 2A, 2B, 3A, 3B was so tough, standardization was a tough. Nevertheless, with the advent of ICG fluorescence cameras, sentinel node has also come. So that's why you know that if you read this central, the European 3 years, this is one of the advances now which has very well established and come in the right selected indication which has proved the oncological safety. Now, most of the thing in head and neck SLNB has moved to ICG. Now, beauty of ICG is you give a dye, then you can actually look through both primary and this. You can give 0.1 ml, say at the tongue, base tongue or here, and you can look, is there a contralateral? Any lesion touching the midline or any oropharynx lesion, base tongue, bilateral access is there. So, if you do a right side therapeutic neck dissection like MND, you sometimes do a SOHND on the left if it is N0, or you do bilateral. Morbidity is so high, right? So imagine if you can know whether this particular its location has a bilateral access node, then that's why ICG revolutionized. Now we have ICG in the robot where you do a single port. Now you have ICG open cameras, India, everything. So near infrared exhibiting the white stars in the black sky effect has revolutionized one of this area. Now even one step above, not just giving a blue dye, identify a specific ligand in head and neck which can go to metastatic lymph node, injecting them and looking at them. Like for example, we all know that cetuximab is a very good ligand binder for squamous cell carcinoma. That is why in advanced head and neck cancer, cetuximab has come. Now there are dyes which are cetuximab, bound, which can be used to know lymph nodes involved or not. Remember, when you do sentinel node, it will never say positive or negative. It will just say which is the first echelon node which is draining that primary. So you put a neck incision, remove that, then you do a multiple serial section, IHC, and no positive or negative. So you can decide neck is treated by neck dissection or RT or what you do. But sentinel node will never show it is positive or negative. It is shown by pathologist. But now if you can do a ligand bind which can show that it is positive node or negative before by an imaging. Now this is that is what is already started coming and available. Please read this paper, specific ligand of IRD dye 800 CW to identify this patient as a metastatic neck node or not. Remember, even PET scan is not sensitive or specific for metastatic node. All the positive finding of a PET scan on a node has to be confirmed by biopsy. Just because PET is positive doesn't mean it could be infective, inflammatory, tuberculosis, or even a small metastatic foci PET can miss. Whether you do FAPI PET, FAPI therapy, still it is. So this is a good way. So the way forward, one of the technology that is happening in the clinical research is specific ligand bind, and they have found a way on the imaging and compared with the cytokeratin IHC, this test itself will show positive or negative. Okay. Second thing is intraoperative assessment. You know, when you go with a lesion, you don't know where is the margin. So what is common cell carcinoma? 1 centimeter tridimensional margin. Larynx, millimeter, 2 millimeter. Hypopharynx, 2 centimeter. For every cancer in the body, there is a margin which is prescribed by HACC TNM board. How did they arrive at? Over last 10-20 years, our teachers, seniors did various study. Okay, 1 millimeter margin, what is the recurrence? 2 millimeter margin, what is the recurrence? 1 centimeter, 2. Then they have found that at this margin, 99% of the patient can have a negative margin in histopathology and the local recurrence is less than 2 to 3%. Over various trials, they have arrived. So if you open the big manual, TNM has 2 books, small handbook, one big book. Please read the big book. Margins for all the solid tumor is written. Oral cavity, tridimensional 1 centimeter. Hypopharynx 2 centimeter. Larynx 1 millimeter. Then esophagus proximal 5, distal 2. Stomach proximal 5, distal 2. Colon proximal 5, distal 5. Rectum proximal 5, distal 2. Okay, breast cancer negative margin at the ink. Squamous cell carcinoma, skin, basal cell carcinoma, melanoma, for all of them. So as a surgical onco trainee, please write margins for all the solid tumor as prescribed by HACC. Okay. So now what if you can know by a special intraoperative imaging, you shine through. This is the margin. This is where the precancerous change ends. This is where the dysplasia ends. This is where the in situ changes end. Like for example, when you do a cervical cancer, robotic or laparoscopy are open, one day before we take the patient, go to a colposcopy room, we apply a Lugol iodine, then we apply toluidine blue, we put the what is colposcope? It is a high enhanced microscope, and then we look image guided in situ change in the vaginal margin, we mark it, next day we remove that much of vagina. Because more vagina you remove, then there is a quality of life issue. Similarly, more you remove, quality of life, unwanted complication comes. So imagine if you have an intraoperative molecule based tumor glow, then you can really know how it is. So that's why now IVICG given a day before, using an Iridian camera with or without cetuximab ligand and assessing the margin. So you don't do under, you don't do over is coming in a very big way. Also we know that image guided infrared is very well used in parathyroid. Remember, image guided ICG fluorescence is not used to identify parathyroid. If you don't know where parathyroid and you're doing a thyroidectomy, there is a serious problem with you. Please go back to anatomy, then go back to your teacher, assist and learn. If you don't know as a head and neck surgeon where parathyroid comes and you want to search parathyroid, that is not the reason. Okay, you know the percent sign, right? Parathyroid superior, inferior. Inferior comes with the same pouch as thymus, so it is dragged down, and superior develops for a different pouch, so it is there. No matter the position, height vary, percentage sign will never say. Always superior parathyroid is superior posterior to the recurrent nerve, inferior parathyroid is always inferior anterior to this. Parathyroid fluorescence is you have completed a surgery, end artery, you don't know now that is vascular or not. Most common cause of hyperparathyroidism is not removing or destroying it, but disturbing the vascularity. You give a IVICG after you complete thyroidectomy. Whenever I do a thyroidectomy, whether it is robotic or open, minimal access, at the end of the surgery, give IVICG, 2 mg per kg body weight. In 60 seconds, parathyroid should glow as shown here. If the parathyroid don't glow, its artery has gone. Then remove the capsule, open it, implant, and then do. There is a very beautiful textbook called a Complication of Head and Neck Surgery. Please read that. Implanted parathyroid into sphenoidomastoid, 76% they function at 6 weeks to 8 weeks. So, you know, it's very high. So, this is also to know whether patient will end up with a hypovascularity. So these are all image guided surgery. They can be done with ligand, without ligand. I'm just introducing you to that. There is no end to that. If you can divide a different type of camera which can show where the margin end, where is the volume of the disease, where in situ changes, which is metastatic node, which is not metastatic. Imagine you just have opened the neck here and you can give a ligand bind cetuximab and you can know this particular node hidden here in the 3B is a positive. That's all you need to remove. Okay. Next thing. As you go to infratemporal fossa, hypopharynx, skull base, 3D reconstruction. So the next advantage is a computer assisted 3D software to get. So you can wear a VR glasses. What is Google glasses are there, or Apple glass, and imagine if you can get an idea when you do a parapharyngioma, neural tumor, or you have a styloid compartment disease. So you have a paraganglionoma, or you have a pharyngeal tumor, or you have got a deep lobe tumors or skull base. If you can get an idea, okay, where is foramen oval, where is this relation, what is close, what is the course, anterior, posterior, imagine. So if you can do, I will tell you one more thing. Not many of you know that if you have a true beam or a IGRT or IMRT in your center, which most cancer center have, if you give your high quality CT scan to your radiation onco, they will be able to beautifully in their software able to tell like this. Can you see the last image? The entire shape of the tumor, volume, asymmetry, all the vessel nerve structure, esophagus, how close they are, and they can make a 3D for you. Nowadays we have started this habit, you know, you don't have to have an iFunda CAD-CAM software or a technology. Your CT scan of head and neck, you go and give it to your radiation onco, tell them I'll come back tomorrow. Your physicist will beautifully tell how far is the vital structure. So try to get an idea, especially infratemporal fossa, skull base, posterior petrosal lesions, or a pharyngeal tumors. So you can analyze these things. So this is one of the technology. Yeah, what I cannot see, brain cannot interpret. What brain doesn't know, I cannot see. So that's why. Then what is the advantage of this? Once you make a 3D image of this, you can do a 3D printing. You know that in all over India, multiple places, I use a company in Pune. Recently, just now we got a 3D printing done. Routinely a beautiful coated, you know, wherever you 3D implants can be beautifully done. So the extension of this imaging and planning is you can do 3D printing. There is no end to the material. You can use actually, you know, a titanium powder. You can use whatever material you want to use, and various dental rehabilitation, skull, head and neck rehabilitation. There is no end to this in the life. You can even know what cuts you have to keep, how to keep it with the software. So you can go back. This is one of the advances. Next advances is, which was already a past, future, and also changing rapidly, is laser. You know that laser can make you reach an area. Don't think that okay, there is a leukoplakia I use for laser. That is not the recent advances. When I was a surgical onco training, people didn't have money to, you know, afford Provox 2 prosthesis. It used to come from Switzerland, Zurich, and the brush itself was 2, and it was very expensive. Life was 1 year. So then we used to do near total laryngectomy, where unfortunately we couldn't have put this. Then microlaryngeal surgeries came, then antral surgeries, then advancement in radiation avoided it. But then the laser evolution, able to use in the robotic platform. You know, like the robot I have, the luminous laser which everybody uses, CO2 laser in head and neck. How many of you know that the luminous laser has a special robotic laser drop instrument you can purchase, which I have purchased. The robot has a special attachment for laser drop, which is available already. I didn't know that until I traveled world. So there is a laser attachment in the robot. There is a special robotic drop available in the luminous. So if you can do both, imagine with one arm of the robot and camera, you can go deep down into an area. How you can do a postpharyngeal excision, supraortic excision, laryngeal excision, tumors excision. So laser advent, not in laser per se, using with robot, with endoscopic. There are many types of laser, you know that CO2 laser are there, KTP laser is there. The benefits you all know, precision, bleeding control, faster recovery. So using in the advancement and the microscopic. Now all the lasers come with the microscopic advancement, you know that, because stability is very important in this. So you can go down up to 4 centimeter between the microscope to this, which means you have another. So how far you can use? Micro manipulators are available, micro motors are there. So you can use them through various. So Mayo Clinic conducts this course every year, laser microsurgery in head and neck. It's a fantastic course. I recommend all of you to please register, Google and do. You can see that. So for a head and neck surgeon who have taken that as your profession, Mayo Clinic transoral laser workshops are fantastic. Please go and see. See, you can even reach up to cricopharynx. What all you can do with this area, you can do release the sphincter here if there is a spasm. So not just communicating to here, you can go down. So this MRT or Dunnery excision, everything is gone, then a photodynamic therapy. There are two types of photodynamic therapy. The general principle is you use a photo-sensiting dye given through IV. It also comes in gel. You know, I quite often use posterior pharyngeal. There is a gel. If you apply gel, you need to wait, quite some time. If you give IV, usually you can give depending on the access 24 hours before 72 hours. So the dye comes in a gel format or IV format. In a non-accessible area, you can use, or it is for a palliation for advanced. Now there are two types. You shine through with a type of laser which excites only the cancer cell which has taken this dye and it kills. There are two types of laser. You can shine through from outside or you can do through interstitial. Photodynamic therapy, interstitial is also available. There is a big fungating mass. You can put the interstitial, this, and the laser only goes in after photodynamic and it takes. So the normal area, then the photosensitivity, complication, necrosis, osteoradionecrosis, then eye issues, skin issue don't happen. So you don't have to, keep that patient hidden in a dark room for 3-4 days. You can give interstitial PDT and interstitial laser demonstration. So these are all available and you can accentuate with the hyperbaric oxygen therapy available with this. So these are all the various places. Can you see? Suppose imagine there is a T1 hyperpharyngeal lesion. You can't do a robotic. You can do an interstitial PDT. So these are all evolving. Please don't take it as level 1. These are done by expert centers. Or there is an isolated neck node, supraclavicular fixed. Everywhere it is cleared and you can't go in. It is stuck to the vessel, already post irradiated. You can do this. See this needle, interstitial PDT. With interstitial laser you can do. So these are all the advances that has come, and there is enormous advantage for localized early, for advanced disease, for palliation, for curative, contact PDT, non-contact PDT, or suppose there is a hidden disease inside the maxillary sinus, how through the functional endoscopic sinus you can do. Please expand yourself on that. I'm not going to bore you. Multiple surgery done and then this lesion cannot be excised. A PDT can actually also take care. So please read and understand. This is one of the advancement. That itself is a big book. There is a PDT in head and neck brought by Springer, this much big book. I have it in my library. Just you can run courses on that. Now second thing, I got exposed to this in Germany. This is an extremely important thing I want you people to understand. Remember, don't confuse a chemo given by IV. IV chemo first goes to heart, veins, dilutes, goes to liver, first pass of the chemo dead, small fraction goes to the primary tumor head and neck. So it doesn't have enough concentration to kill that cancer. However, it will cause hair loss, bone marrow suppression, skin becomes black, weakness. Now imagine if you can go and see there is a parapharyngeal tumor. You can go to carotid, you can go to external carotid, you can go to ascending pharyngeal, you can go to a branch of the ascending pharyngeal, give a chemo, 1/100th of the dose, 1/10. That is a very high dose, enough to kill, and first pass it gets killed. So that is intraarterial. There is a famous, very good head and neck surgeon in Germany. He runs courses every year. I attended his courses several years back and I try to percutate intra-arterial selective chemo for head and neck cancer. Amazing results come. So these are called as thermo-chemo radio. With heat, with intra-arterial, you go and identify. It could be palliative, it could be curative. Imagine that you have done it, keeps recurring. What would you do? You give radiation, gone. Palliative chemo, gone. Cetuximab, nivolumab, nothing. Patient is neither dying because there is no systemic meds. They die with blood, cancer cases, and nutrition. Always explore intraarterial. I use intraarterial chemo in my practice extremely commonly. You'll be surprised sometime what cannot conventional can do. So you do angio, there are special balloons, you go there, block contamination of the, you look, if you give a test dose, what is the skin dose and what is the tumor dose, selectively put a balloons, block the blockers, and then put a glue, unwanted going to head, then you can do this. So please read this about this. I cannot do, lot of paper are there. There is one this much big book written. Those of you interested can contact me. I can give an access if you want to do a course. Ideally, I recommend a head and neck surgeon should be able to do their own angios, own reconstruction, do a own intraarterial. Any palliative head and neck, please try intra. Don't call it a day. Tell that patient you are dying, you go to hospice until you have tried intraarterial chemo. You'll be surprised what it can do for those patients. How you can go back and then do. You can identify individually or surgically. Surgically, if there is a tumor which is not sensitive to chemo, intraarterial will be sensitive. What we try to normally is you go there through the superior thyroid artery, keep the Grosjean tip catheter, and you can put a pump, and pump based you can do. Imagine advanced nasopharyngeal cancer. You have done a chemo radiation, not controlled. You have done a surgery, not controlled. Everything is gone. Second, third line. If you can open the neck, go through the superior thyroid artery, put a pump, and then you selectively can do through a pump chemo infusion. There are very indications. You can go back and see something which cannot be in it. These are all the book I carried from the book which is written by the German. So how intraarterial in head and neck is great. Multiple surgery, multiple radiation. Can you see this disease? You have this fungating mass on the skin because of dermal lymphatic spread. You operated, neck dissection done, lymphatic is disrupted. A right intraarterial dose of 1 or 2 can actually give a good palliation and in some time a prolonged locoregional control. This is one of them. Second, enhancing the intraoperative imaging, which I told you. If you can do ligand bind, molecular bind, metabolism bind, vascularity bind to improve accuracy real time in the imaging. So this is the virtual surgery that has come in head and neck surgeries. Combined application of virtual surgery and 3D printing, wearing these glasses and operating the tumor. It's already come in robot. You know that those of you who do robotic surgery or laparoscopic surgery, you can actually, put this virtual glass. And then once you put the virtual glass in the laparoscopy, you don't have to look the monitor, you don't have to look the robot. It is already available in Indian SSI Mantra. Those of you who are using SSI Mantra India, if you have Apple glasses or a Google glasses, now they have developed their own glasses. You can just sit like this in the hotel room. You don't need a monitor, you don't need anything. With the electronic gimbal, you can actually operate with 360 degree and you can look back, see the OT, see the patient, see the monitor. So this is already available in minimal access surgery. Now the same thing VR application has come in head and neck surgery. Recently, I saw one of the ENT surgeon demonstrating a parotidectomy using this VR technology. One of my cousin is actually working in US on this, and then they brought this virtual thing where it shows magnification and you can sit and operate with the 3D. And what is fed to that? Like this, see, you're sitting in a OT, the CT pre-op, this VR software converts into 3D. As you're operating, you can see the operative field. You can also see how this tumor, can you see this? Suppose you have a chemodectoma or you got a carotid body tumor. You know where the internal carotid is arching and here what branches you need to sacrifice. And as you're operating in the VR glasses, three-dimensional overlap of the VR image is happening. It is already available, it's already there, and then it's being done. You can go and attend the workshops also, and there are devices already. My cousin had developed, he had brought it to my Aster Cancer Hospital recently, and we just tried it. But in US it's available, and now in several years it will be available for everybody. So augmented reality now. Now how do you use ChatGPT? People have all this AR. How do you have artificial intelligence? Suppose you are starting a dissection. Imagine if your artificial intelligence can tell you, if you start here, there is a 95% chance you may end up injuring the vessel or opening the tumor. If you start from this area, the plane is easy. So imagine if the artificial intelligence says when you start, suppose there is a stuck neck node or there is a salivary gland deep lobe of carotid. If it can say what area each step where you continue has the best success rate. Now this augmented artificial intelligence reality is also come now. So a lot of development is happening, and its main use would be in skull-based tumors, and then deep parotid, paraganglionoma, and craniofacial resections. So this will predict analytically what continuation has the best success rate and least chance of tumor margin being opening up, least chance of ending up with disaster in that surgery, and each surgery it can be a tailor-made. Next option is telemedicine. Recently, you know that I sat in the Delhi Gurgaon SSI Robotic Center. We operated a surgery. Now in India already available. Now we are preparing to do a surgery from Bangalore Aster to Cochin Aster, and I'm planning to sit in Bangalore and operate in Delhi. Planning to sit in Delhi, operate on my patient in Bangalore, because there is a transoral robot that's being developed, and this robot in SSI Mantra is amenable through a broadband you can do. So the remote telesurgery in head and neck is also come. Please read about this paper. I put it here. It's an open access paper. Artificial intelligence based methods in head and neck cancer diagnosis and overview. Both diagnostic, pre-op planning, intraoperative imaging, and imperative analytical evaluation. So please read this. Input, extraction, machine learning, prediction. How it has changed. Because I am into my last 5-10 minutes, I can't too much spend on time on this. Please read about it. Second, how the artificial intelligence in head and neck cancer. This is a beautiful education book which is brought by American Society of Oncology. And the radiomics in head and neck has brought opportunities, mechanics, and challenges available. So the advent of this large machine learning coupled with intelligence. Now this is a era of artificial intelligence. ChatGPT, AI, you can see how Google, Apple, Tesla, everybody has jumped. Now you will see in 1 year unimaginable AI coming into real time, not one of the Terminator movies we saw when we were kids, and still today it has not happened. No Terminator has happened. But now in 1 year you will have already how the artificial intelligence can impact the head and neck surgery. Is a beautiful paper. Please read the recent advances, you will know. The next recent advances which is a reality today is intraoperative radiation. You know that if you have done a surgery, you actually know which margin is closed. Imagine you have done a deep lobe of parotid, you have gone to skull base, you removed everything. You think that at the foramen ovale, microscopically you don't know you achieved or not. If you close the area, post-operatively, after 1 month, you have to give radiation from outside, skin, deep lobe, everything is irradiated. Patient has to come for 6 weeks because one high dose you can't give. It will burn the skin, it will create a hole in the pharynx. But how to do it? So intraoperative radiation. So this is very important in head and neck now. Re-radiation. Suppose you operated, second recurrence in infotemporal fossa, already EBRT given, there is no radiation. And you know that a good surgery coupled with a radiation can give a good control. So intraoperative radiation, one machine, this was the machine which was IORT brought by Carl Zeiss. Now today, the Estro and Astro has brought a guideline. A X-ray based machine should not be used, but you should use a electron based imaging. So now there are linear accelerator which is put into the robotic arm weighing only 500 kg, which is available. You know, this is the machine which is available, and this is a surgery which we just did day before yesterday. Me and Dr. R.P. Dev, our head and neck surgeon, we did this. This patient had a deep lobe parotid tumor, operated 4 times abroad, 2 times EBRT given over last 10 years, always recurring at the skull base in the foramen ovale in the skull base. So you can see that the external carotid artery is tight, this is there, and we did a surgery, and only to that area, this is actual photo of mine. The only intraoperative robotic linear accelerator in India is available with me. We are using it. You can see this takes 60 seconds. This is a magnetic cone. This whole machine is just 500 kg. We operate. This is the skull base tumor which we resected, 2 times irradiated, 6 times operated. This is a robotic arm which holds there, manipulates, and you know when you are there, this is the machine which uses, you can see that this is the lead. We are outside and inside, and there is a ultrasound which you do called TPAPs. It tells what was the pre-op marking, which margin is likely to be closed, and then we give intraoperative. Now there are 858 papers on IORT in 2007 journals. Now in routinely in the body, I use IOERT, intraoperative radiation. Remember, this is not the IORT. IORT is not a safe technology. It is a X-ray. IOERT is a fully available intraoperative linear accelerator, high dose electron activated, 60-second whole treatment is over. You can give at the skull base. Suppose there is you are doing a neck dose and you shaved it from carotid. EBRT is not superior. You can do a single dose of IORT. Surgeon knows which margin, 60-second operative over. No need to change the OT in this new machine which is available. So you can imagine these are some of the cases, recurrent malignancy in the hard pellet, and these are multiple applicators come, the robotic arm can turn anyway in the machine. This machine is there. I'll try to do with help of Kaustubhai, role of IOERT in head and neck cancer. Probably I'll do a workshop with you people. I've done a lot of cases over last weeks, and we are going to call some expert from Italy, and maybe I will do one workshop on intraoperative radiation in this. So these are all available, no longer future, present. It's already available. See this, you do a re-excision, you put this cone and you irradiate. No radiation required later, one shot, 60-second over. Normal area is all separated. You know what we did here? We wrapped the carotid with and we took back. And there was a lingual nerve, we separated it. Then the article, all the vital area move out, 60-second you do intraoperative radiation and come back. You can see that multiple surgery is done and recurrence. You know that already EBRT given. If you do surgery again, you don't know where the lymphatic emboli margin is there. So you can see excisions, intraoperative, this is the radiation through the electron. Now new technology called flash has come. In head and neck cancer, 6000 centigrade is required to cure. But you cannot achieve that in all the patients. This is called as a flash electron. The machine which I have taken has a flash electron, and it can give as much as 10,000 centigrade to one area with leaving the normal area. So there is nothing called radio resistant. What we thought as radio resistant, adenoid cystic carcinoma, salivary gland, we say radio resistant. It is radio resistant up to 7,000 centigrade. Beyond that you can't reach in EBRT because of complication. But flash 10,000 can actually take. It's a new technology, read about it. Madam Curie Cancer Center has brought it. This is called electron flash. So these are all the papers which are available. Intraoperative radiation using IV cetuximab as a radiosensitizer. This is called bioradiotherapy. Please read about this. HER1 therapy ligand you give 2 hours before, tumor will sensitize, then do intraoperative radiation to the neck. And this is also, read about this trial called as trampoline randomized BORTEC trial, how the radiobionics has come back. Okay, so I will end in this because I can't continue forever. These technological advancements are so much. I can do a 1 full day course in head and neck. There is advancements in chemo, there is advancements in radiation. Now hyperthermia, heat with radio frequency and ablation is coming in a very big way today. And then the imaging, narrowband imaging is available with GI people. But imagine, we say oral cancer surveillance. If you have a handheld device connected to your iPhone through an app and it shows a narrowband imaging, and you know which mucosa is abnormal, which leukoplakia is abnormal, where you need to do post-RT, which area, first part, you don't know hyperemia because of RT, primary tumor. Now narrowband small probe attached to your iPhone with an app and screening patient and sending them back and identifying early recurrence. So this is the reality today. Narrowband imaging in head and neck. Read about this paper, recent advance of intraoperative imaging, both pre-op, screening, surveillance and surgery. So remember, don't get carried away too much with technology. A machine, a fool with a tool is still a fool. It is the man behind that machine who can interpret. So technology, a knife can be used to stab, can also be used to cut an apple and eat. So it is for you to know the difference between what can be done, what should be done, what is operable and what is resectable. So thank you. I have to end my talk because we completed 30 minutes. As I told you, as a mentors and teachers, our job is not spoon feeding. You're not in first standard, second standard. We show direction, we stimulate your brain, we show a path. You as a student has whole life to walk on that. Today Kaustubhai is my senior. When I was a resident, he was a boss. Even today he is learning. He traveled across the world. He was the first guy at that, several decades back, traveled world and brought best technology in India. Even today he is learning. I'm his student, even I'm not even 1/3 complete my learning. So learning is a continued process in your life. As a teacher, we stimulate you, we show a path. You have to walk, develop it, and we don't spoon feed. Okay? Thank you very much.
Thank you, Som. It was a lovely overview of recent advances. Actually, I want all the trainees to understand what is a cancer surgeon and what is a surgical oncologist. See, Dr. Som has made you not only aware about the recent advances, the skill of surgery is one part, when to do and why this new technology, where it helps. All these are the important questions which only a surgical oncologist must understand, so that he can implement all these recent advances into a true direction. The problem is that the surgeons always think that surgery is the skill. It's not only the skill. Yes, skill is important to learn the new advanced mechanism, machines, directions. These are important, but you must understand the logic behind these advancements, why this has come, where it will help. The indications are the most important thing you must learn about, and that is what an oncologist means. An oncologist is a 360-degree understanding of oncology, and that is what Dr. Som has made you understand. He has not just enumerated robotic, laser, these and that. He has also told you why this has come, where it is applicable, and also not only the surgical advances, he has also made you aware about radiation, medical oncology, the new ligands, how to apply that in your surgery, and all these things makes you a 360-degree surgical oncologist. So this is what is important. Whenever you learn a skill, a new skill, you must also learn why and when. And that is what is important, what Dr. Somsekhar has said. Som, this is a wonderful presentation. I myself learned a lot from this, and I'll continue learning whenever you are speaking. Thank you so much.
It's your greatness, actually. We all followed your surgery coupled with knowledge and humbleness. Thank you. That's what our students has to learn from you also. Thanks. Thank you.
So there are few questions. Akila has asked which textbook, head and neck surgery book you mentioned. I think it was JP Shah's textbook of head and neck surgery. It's not the atlas. It is the textbook.
Also, from the Bethesda, from the head and neck unit by Strott, there is a book called as Complication of Head and Neck Series. Please read that. It is a 1000-page book. That's one of the best book I've ever read about head and neck. JP Shah textbook, Atlas Operative, Ramon Tiwari textbook is there, then McGregor. But Complication, I learned more from this book. I have this copy with me in my library in Bangalore, but I'll take a photo of the first page and I'll put it in the group we have for Telegram and WhatsApp for students. Please read that. You will be astonished. The thyroid, the parotid, skull base, Complication of Head and Neck series, one of the best book I've read. It's a 1000 book. I will put the copy of that in the group for you in the WhatsApp and Telegram. You can read that. Good. I think we have to then end it. And thank you, Dushant. You and Kaustubhai